Welcome to our podcast, Eye Hackers.
Well, I'm not a big fan of self-pricing.
What is the percentage of monofocal toric or multifocal toric?
I began my career in a state hospital.
In Vietnam, toric IOL implantation is quite rare.
I was recognized for having performed the highest number of Toric IOLs.
Tips and tricks for toric IOL implantation. So the one who is faster wins.
Yes.
Eye Hackers. Good afternoon, dear colleagues and patients. Welcome to our podcast, Eye Hackers. Our topic for today would be tips and tricks for toric IOL implantation. I'd like to introduce my dear friend, Dr. Evgenii Chernov, a leading Vitreoretinal and Cataract surgeon from Russia, Vietnam Eye Hospital, to join this podcast today and share his expertise on this theme. So cataract is one of the leading causes for blindness. For 2020, almost 15 million cases had cataract and went blind, which comprised 45% of global blindness. However, with the development of modern technology, cataract has become almost as refractive surgery because patients want perfect vision at all distance. That's why we decided to start this topic, because in Vietnam, toric IOL implantation is quite rare. And in Russia, it is one of the routine surgery for cataract surgeon. That's why I'd like to invite Dr. Evgenii Chernov to join this podcast and share his expertise. So can you please start with why did you choose to become an ophthalmologist? What is your background? Maybe for our colleagues to know more about you.
Okay, I will start from the beginning. So to be honest, until the very last year of medical university, I was determined to become a general surgeon. So I spent countless hours assisting in surgeries, living in operation room. And my senior colleagues were shocked when I suddenly shifted to ophthalmology. They couldn't believe it. And I'll admit I had my doubts at first, but the more I delved into this field, the more I realized I had made the right choice. So there's a precision, a beauty to ophthalmology that completely captivated me. I began my career in a state hospital in a small town. It was a good start, but I quickly realized I needed a bigger platform to truly grow. Over time, I moved to different places, gaining invaluable experience along the way. My turning point came when I moved to Sakhalin Island. Within a few years, I became the only vitreoretinal surgeon there, leading the ophthalmology department in the region's largest hospital. Eventually, I became the chief ophthalmology, but I always had a dream of working abroad. When an opportunity arose to join the Vietnamese Russian Eye Hospital in Hanoi, I didn't hesitate. It was a chance to broaden my horizons, both personally and professionally.
So can you please share about your recent prize that you just received?
Well, I'm not a big fan of self-pricing, but since you ask, recently I was recognized for having performed the highest number of Toric IOLs implantation in northern Vietnam.
Can you please share how much exactly cases did you implant?
Really not much. It was a little bit more than 100, but in our hospital, all surgeons were implanted around 500. But in northern Vietnam, about me, I implanted more than 100, but it was just size Toric IOLs, because we also have Toric IOLs from another manufacturer, it's Alcon. So both, I think it's around 200.
200. So the first question I'd like to ask you, what is the percentage of Toric IOLs do you use in your current practice? Like, what is the percentage of monofocal toric or multifocal toric? IOLs?
In my practice, I'd say about 40% of cataract surgeries I perform with Toric IOLs. Most of these are monofocal, of course, probably around 80% of the toric cases, but the remaining 20% are multifocal toric lenses. They are great for patients who want to correct their astigmatism and reduce their dependency on glasses for things like reading or working on the computer. Of course, the choice really depends on the patient's lifestyle and expectations.
So, dear Dr. Evgenii, can you please tell us what kind of patients are eligible for Toric IOLs? Like, what is the criteria for selection?
Yeah, this is a really good question because too many debates between surgeries, between ophthalmologists, who is exactly patient for who is candidate for Toric IOL. And I say that patient with astigmatism of more than 0.6 dioptries, especially when the astigmatism is positioned in a way that the main incision enhance this effect. It's important to remember that a Toric IOL with only one diopter correct just 0.7 diopter of astigmatism. So patients with 0.6 diopters can be candidates for Toric IOL surgery. Recent studies also show that Toric IOLs are a great choice for patients with irregular astigmatism, such as those recovering from corneal trauma or surgery done before. They offer a significant improvement compared to standard IOL.
So 0.6 diopters, you said, is it just corneal astigmatism or it's total astigmatism value?
You mean corneal and lens astigmatism?
Yes.
No, of course, we looking only at the corneal astigmatism because another astigmatism with crystal lens will be removed because we choose this crystal. So usually
0.6 is corneal.
0.6, yes, it's corneal astigmatism. Let's say it's total corneal astigmatism with anterior surface and
posterior surface.
Yes.
So you say that Toric IOLs are ideal for patients with the astigmatism when it's positioned in a way that the main incision enhances the effect. Which degree are you talking about when the main incision can enhance the astigmatism?
It depends on position of surgeon because if you sitting
on the head,
it will be from 180. Depends of how surgeon get used to
making the
main incision. Yes, of course. So for me, it's almost always 160. But I also can choose a little bit this position if I need to reduce astigmatism. If your astigmatism, for example, in my situation, if astigmatism around 70 degrees and my main incision is 160, so with this incision I will be enhanced astigmatism. So if patient has astigmatism around minus 0.7 or 0.8, so we can have -1 astigmatism in outcome. So it's better to think about to choose
Toric IOLs.
Yeah.
So what about total keratometry? Do you take into account the total keratometry?
Of course, because posterior astigmatism is also can affect to total astigmatism, and so of course it's much smaller than anterior astigmatism, but when it's sum,
into the sum,
so it will be a little bit different. Sometimes it can change for 0.5. Especially if we have irregular astigmatism. So anterior astigmatism and posterior astigmatism can be different. Not
Yeah,
totally,
different
yeah.
data.
Especially if patient had surgery with pterygium or it was trauma with perforating astigmatism with suturing. So these scars can be different.
Yeah. What about the pupil offset data? Like, do you take that into account?
Pupil offset data as well as angle kappa are especially important when we're using multifocal IOLs. Angle kappa refers to the distance between the visual axis and the pupillary axis. So this difference can be affected if this angle more than 0.4. So some devices like IOL Master or another can calculate this angle, and patients who has a big angle can have side effects like hair loss or glares with multifocal, especially with trifocal lenses or five-focal lenses.
Like Hanita.
Like Hanita, yes.
So I know that you are a vitreoretinal surgeon. Are there any retinal conditions which are exclusion criteria for toric IOLs or not? Are there any retina problems like maybe AMD? For example, if the patient has AMD, he cannot go for toric IOL, or he still can be a patient considered for toric IOL?
For retinal issues, these don't usually exclude a patient from receiving toric IOLs, except in cases where central vision is entirely absent. Even with notable retinal changes, correcting astigmatism during cataract surgery typically results in better overall visual outcomes. It's all about tailoring the approach to optimize the patient's vision. So if we have patient with pigment retinitis or AMD, and this patient also has astigmatism around -3 or more, so of course it's better to put toric IOL. But if patient has dry AMD with total atrophy, like geographic atrophy,
Atrophy.
so of course no need to think about toric IOL because this patient do not have central vision. Yeah.
So what kind of toric IOL do you use in Russia? How long was the waiting time for the toric IOLs?
So when I worked in Russia, I was based in far east of Russia, so it's far from central, from the big cities.
Far from Moscow.
Yes, of course, very far. So we didn't have any stock with toric astigmatism. Nearest city with toric IOLs, it was, I guess, Novosibirsk. So it's almost the middle of big, huge country. But hopefully for us, we had a direct flight. So we waited around 2, sometimes 3 days for ordering our IOLs. So, but about multifocal, I think we also waited a little bit longer because it comes from, I guess, Moscow or order it from other countries.
What kind of toric IOLs do you use in Vietnam now? And what is the waiting time now here in Vietnam?
Just like in Vietnam, we had access to 2 major manufacturers, Alcon here and Zeiss. And what interesting is that the ability was different. In Russia, Alcon toric IOLs were more accessible, while Zeiss lenses often required more time to procure. Here in Vietnam, it's the opposite. Zeiss monofocal toric IOLs are stocked locally, while Alcon lenses are not as really available.
The next question definitely interests a lot of our colleagues. What kind of formulas do you use for IOL calculation, like Z-Calc, Alcon, and in case if the Toric IOLs don't come from these two companies, what kind of formulas do you use?
You know, recent year, more than 1 year, for Toric IOL implantation, here I always use the form software from Zeiss. It provides detailed and accurate results. So it's IOL Master 700.
Yeah.
And if we need more detailed topography, we use Pentacam.
Mm-hmm.
In this software, we have many formulas, but most of them, if we're using size, we have two choices. The Z-Calc formula, a special formula for sizes lenses. But I prefer Barrett-Suit because this formula include not only keratometry but also anterior chamber depth, yes, and white to white size and thickness of crystal lens. So I think it's more precise for IOLs. And when I try to calculate both formulas, sometimes I can see difference around minus 0.5. So now I'm trying to understand, and sometimes I'm using Z-Calc, sometimes Barrett-Suit case, and maybe later I will analyze these two formulas and will be understand more. But now I, of course, prefer Barrett-Suit total keratometry, of course.
So for other surgeons that don't have the size forum, how can they calculate? Just go online?
Yes, you can use online calculator, a lot of online calculator. Yeah, if you using Alcon, IOL or size, they both have their own calculator, online calculator, and you can choose any formula that they have. If you want to compare predicted outcomes or results, you can use another formulas. Now we have formulas with artificial intelligence. Yes, of course. So it's much easier for calculating. But yes,
online would be a good choice.
Online would be good choice, yeah.
So how exactly do you advise the patients to go for Toric IOL? Like when they ask for Toric IOL, they'll ask, will I get a perfect vision 20/20? Will the astigmatism completely go off, or will I still have some astigmatism? Because Toric IOLs are more expensive than just a normal monofocal IOL.
When I talk to patients about choosing a Toric IOL, I always make sure they understand that these lenses are great for correcting astigmatism, but the results can vary depending on several factors. I explained that while Toric IOLs can significantly improve vision and reduce or even eliminate astigmatism, I can't promise perfect vision like 100% or 20/20 because every eye is different. I also emphasize that no artificial lens can fully replace the natural lens, especially when it comes to focusing. The natural lens has the ability to change its shape and focus at different distances.
Accommodation.
Yes, of course, which is something artificial lens can't do. So even though Toric IOLs can provide great results, the focusing ability of the eye may not be exactly the same as it was with a natural lens. The goal with Toric IOL is to get the best possible correction for astigmatism, and most people see a big improvement in their vision.
So how do you measure the Toric IOL post-operative position. What is the acceptable degree of toric IOL rotation? What happens if the toric IOL rotates more than acceptable degree, like more than, I don't know, 5 or 7 degrees?
Yeah, exactly true. But after implanting all toric IOLs, I carefully monitor its position using with just slit lamp. It's very easy. And check the patient's visual acuity with correction. The first evaluation is performed on the 5th day after surgery, and the second check is done 3 weeks later. The 5th day assessment is important because by then any swelling in the corneal tunnel has usually subsided. So it doesn't affect refraction much if the IOL's position is within 3 to 6 degrees of the intended axis. There is no need for any intervention. Residual astigmatism up to 0.5 diopter is acceptable and doesn't typically affect visual quality. However, if the IOL rotation exceeds 10 degrees or more from the intended axis, I would recommend a secondary surgery to reposition the lens. This would help align the IOL properly to correct any significant astigmatism and restore optimal vision. As shown in study by Indian surgeons in 2020 by Dinh and his colleagues, most of rotation of the toric IOL occur within the first 24 hours after surgery, of course. After 1 month, after the first month, any further rotation is typically very minimal and usually results from slight contraction of the capsular bag. Knowing this, we can be confident that if the toric IOL will position it on the 5th day, it's likely to remain stable in the long time.
So, did you ever have a patient who went for excimer laser ablation as a second stage? Instead of rotating, but you would use excimer laser to get rid of residual astigmatism?
Of course, if we skip this period for any reasons and capsular bag already contract and hold lens in this position, so it's better to use any
Other methods?
Other methods, yes. And refractive surgery, of course, it's very good. But we have to be sure that this lens inside eye it have good stability
already
without any
rotating,
not rotating, but without weakness of
the zonules.
Zonules, yes. Because if we can have in future any dislocations of IOL, so it will be very difficult to put this IOL to right position because we changed cornea already.
Yes.
Another one, at the 3rd week check, we assess the risks of capsular contraction and take necessary measures if needed. If the capsular bag starts to contract after and affect the IOL's position, we may consider performing a YAG laser capsulorhexis edge incision to prevent further issues and stabilize the IOL. This ensures that the lens remains properly aligned and that the patient maintains the best possible visual outcomes.
Did you have to do that often?
You mean YAG laser?
Yeah.
Sometimes yes, especially for young patients, when I do capsulorhexis manually.
Yes.
And sometimes it's getting to capsular shrinking syndrome. So if I can see these first signs, of course I do YAG laser dissection of anterior capsule. Exactly, rhexis. Sometimes and posterior both, but it's better to do this laser dissection and you can see how it's relaxing and lens will be on the same position without any moving.
maybe it is better to do a cut at the anterior capsule already during the surgery, or not? Like
I'm not sure because you cannot know how capsular bag will be contracted. So it's better to have round shape circular capsular axis because it will be this tense power will be gradually. If you cut or if you will have any rupture of anterior capsular axis, it can be not gradually, and this contraction can little bit move IOL in the capsular bag.
So let's start with the basics. How do you mark the toric IOL manually?
I actually prefer not to use dies marking the toric IOLs axis, mainly because they can get smudged or form blotches, and sometimes they even wash away while the patient is waiting. Instead, I mark the axis with a fine insulin needle, which gives me more control and precision. First, I use the slit lamp to find 180 degrees meridian. If the patient has a narrow pupil, I carefully locate this meridian and then make small notches on the corneal epithelium at both sides of axis. Next, I found the 90 degrees meridian and make notch there. So we have 3 points and these notches are very helpful because they are visible on the cornea and stable. Even under the microscope during surgery you can see this, and they don't shift, don't wash, don't move, and you can apply your round circle.
With the rotational instrument, degree instrument.
Yes, and with this instrument you can
mark the
necessary angle. Angle. Yeah, I use these marks to guide the ring-shaped marker and accurately place the planned axis for the IOL implantation. This method works well for me, and it ensures that the IOL is aligned properly during surgery.
So you need 3 notches, not just 0 and 180 is not enough. Like 90 degrees.
To be sure, yes. It's better to put 3
notches. I know that you use Zeiss forum system. Do you see a big difference in using that system?
Yes, I really notice a big difference when using the Zeiss forum system. It's become a key tool in my practice for several reasons. First, it gives me more accurate and precise data. With it, I can easily check important measurements like keratometry and ocular biometry, which are crucial for calculating the right toric IOLs. The system helps me analyze all the data in one place, which is not only faster but also reduces the chance of making mistakes. Another great thing is how well the Zeiss forum integrated with other Zeiss equipment like the OCT or biometer. Everything connecting smoothly, which makes my work easier and more efficient. I can get detailed, reliable measurements for each patient without jumping between different machines or systems. What I really appreciate is how it helps me track patients' progress over the time. I can easily assess previous records, compare them to the current data, and follow up on how the eye is healing, especially after the surgery, IOL surgery. And of course, it's very easy to use this system for sending data from my computer to Callista Eye. So it's very easy to calculate right lens, send this information to Callista Eye, and during the surgery you can see without any notches, without any instruments, all this data during the surgery, because it's like, eye of Terminator when he looks at every person and knows how many guns he has. So during the surgery, we can see all these axes, size of capsular axis, and where should I do all incisions.
For the surgeon, let's just say, for the surgeon who started to implant a Toric IOL, what are your advices in implanting a Toric IOL?
So we have already talked about the IOL calculations, making the axis and how we determine the planned axis for implantation. Those steps are essential before we even begin the surgery. Now, once we are at the stage of the actual procedure, we start with the corneal incision. I typically use a 2.2 millimeter incision, which is standard for most cases. The position of the incision is important because it should align with the IOL calculation and also allow for easy manipulation of the Toric IOL during surgery. Next, we move on the capsular axis. This step is crucial. The size of capsular axis should neither to be large nor too small. A large capsular axis can make it easier for the IOL to shift post-operatively, especially when we inject the BSS solution during hydration. It can allow the lens to move too much. On the other hand, a small capsular axis can lead to the capsular bag shrinking, which increases the risk of IOL shifting due to deformation.
What is the ideal size for capsular axis?
For me, the ideal size is around 5.1 millimeter. This size works well both for femtoraxis and manual capsular axis. It ensures that the optical part of the IOL is securely covered while minimizing the risk of complication with the capsular bag. The right size of capsular axis really helps stabilize the IOL and provide the best foundation for the rest of the surgery.
What should the surgeon do with the viscoelastic?
It's also important point with OVD, ocular viscoelastic device. When implanting the IOL, I prefer and do recommend use a cohesive viscoelastic, as it's much easier to remove during the aspiration irrigation phase. This is crucial because you want to make sure that all the viscoelastic is thoroughly removed from both the capsular bag and underneath the IOL. At the same time, while I'm making sure the viscoelastic is cleared out, I usually rotate the IOL into the desired position.
So can I ask about the position? I know that some surgeons would rotate it to the correct axis, and some surgeons would maybe leave some degrees. So can you share, please, your experience with that?
It depends what shape of IOL do you use for implantation.
So, I don't know, for example, size IOL, what shape is it? And what is your advice?
If you use flat shape IOL like size, you can move this lens any direction. You can easily move this IOL because of flat haptic. But if you have C-loop, like one piece lens like Elcon or Technique,
okay,
so it's typically better leave around 10-15 degrees before right position, because this IOL we can change position only clockwise.
Only clockwise.
Yes, because if we do this
counterclockwise,
so it can not push but stuck with C-loops.
Yeah.
And you can see like lens in right position, but after then these loops, this haptic pushes and move this IOL to another position. So that's why when we do reposition, if we have wrong position, if you can see wrong position on the second day or fifth day, so you have to go to do reposition. And with flat haptic, you can do very easy without any viscoelastic, with just cannula, with syringe, with BSS, and slightly push lens where you want. But with C-loop haptics, you also can do this.
Yes.
But you have to know if you waited too long.
Yes.
And capsular little bit shrink.
Yes.
So it's better to put viscoelastic in the capsular bag.
Before rotating.
And after then, do all circle.
Rotation.
For rotation.
Yeah.
Yes. And after then, you have to remove again viscoelastic. So of course, for me, it's more easier to use flat haptic IOL. Yeah.
Have you tried Techni's Toric IOL or Anvista Toric IOL?
So I'm using now Toric IOLs from Alcon and Zeiss, and I even haven't known about that Techni's also has Toric IOLs here in Vietnam, and last time on the Congress.
Vietnam Ophthalmological Congress.
So I met guys from Johnson & Johnson, and they said we're finally bring the Toric IOL from Johnson & Johnson here. Yes, they have stock in Ho Chi Minh City, but I haven't used this. I hope I will use in the future.
What is your preferred Toric IOL for implantation?
You know, I prefer that Toric that available during the day of examination, of course, because I do not like when patients are waiting too much.
Long.
Yeah, because it's better. Okay, if we have Alcon, let it be Alcon. If we have Zeiss,
let it be Zeiss.
Yes.
So the one who is faster wins.
Yes.
Do you ever do a scleral fixation for Toric IOL?
I haven't intentionally implanted a scleral fixation Toric IOL yet, but I have encountered cases where a Toric IOL was dislocated into the vitreous cavity due to the trauma or zonular
weakness.
Dystrophy, yes. In such cases, it's crucial to carefully reposition and suture the IOL on the correct axis. And for these cases, navigation system are great help here, as suturing the haptic doesn't guarantee the toric part will align perfectly with the intended axis. Each case requires an individualized approach for the best outcome. So I think the best outcome is suturing IOL.
Yes.
Not fixate for haptic, but it's better to, when we can see on the lens, we can see these markers on the IOL. If we have Toric IOL like from Zeiss,
yes,
they have holes exactly
at the haptics, at the
haptic,
marking.
Yes,
axis.
In the end of mark, they have holes, and
so you can suture there.
Of course.
Yes.
If we have Alcon lenses, so I prefer to put needle through the body.
Through the body.
IOL.
Optical part.
Yeah, so we can put this IOL exactly on this axis. And if we use navigation system.
Yeah, navigation system.
Yeah, so we can see this line. So it's very easy. Not very, but yeah, sometimes it's helped.
So what is your wish for surgeon who begins to implant Toric IOL?
For surgeons, recommendation is just starting to implant Toric IOLs. My main advice is to be patient and take the time to really understand the full process, from calculating the IOL to marking the axis and performing the surgery. It's essential to not rush through any step, especially when you're dealing with toric lenses, because precision is a key to achieving the desired results. I'd also recommend practicing with different types of IOLs and getting comfortable with their specific nuances. Every manufacturer might have slightly different requirements for alignment and positioning, so it's important to familiarize yourself with those details. Also, learn from each case. Whether the outcome is preferred or not, there's also something to improve. Don't be afraid to ask for help or get a second opinion if you are unsure about something. With experience and confidence, skills will grow and you'll see the positive impact of Toric IOL on your patient's quality of vision.
So thank you so much, Dr. Evgenii, for sharing your rich expertise, because I know you are one of the doctors who implants the most Toric IOLs in North Vietnam. So since I told some of my friends about this podcast, I have some doctors asking from Facebook. And I think that they also participated at the Vietnamese Ophthalmological Congress and they saw your presentation. So we have 3 questions. So we have questions from our colleagues all over Vietnam. Hello, Dr. Evgenii. I am doctor from Haiphong. I was at VOS 2024 this year and I saw your presentation. What a great presentation. But there are some points I'd like to ask. Have you ever performed limbal relaxing incisions? Have you performed them before? Because at our clinic we have LANSEC, which is a femtosecond laser, and that offers this method. So do you see regression over the time, or do you prefer implanting Toric IOL over limbal relaxing incisions? And how much degree of astigmatism can this type of incision reduce?
Yes, of course, I performed both manual and femtosecond LRIs in the past. While LRI can be effective for mild astigmatism, they come with some significant drawbacks. Over time, I've observed a regression in their effects, which can compromise the stability of the results. Their effectiveness decreases as the level of astigmatism increases. Additionally, their astigmatism increases and they are less predictable when addressing higher levels of cylinder. On the other hand, Toric IOLs offer far greater stability and predictability. They effectively correct a wide range of astigmatism, including high degrees, with results that are durable over time. Another key advantage is the ability to fine-tune or rotate the lens post-operatively if needed, providing flexibility to achieve optimal outcomes. In contrast, LRIs lack these options for post-operatively adjustments. If the outcome isn't satisfaction, there is no straightforward way to fix it, which is a significant limitation. So while LRI have their place, especially for low astigmatism, I strongly prefer Toric IOLs for their reliability, precision, and long-term effectiveness.
Thank you so much. So the second question comes from Dr. from Hue. Hello, Dr. Evgenii again. I'm Dr. from Hue. I also saw your presentation that you use femtosecond system Zimmer LDVZ8 for femtocataract surgery. Do you feel like using femto system helps you achieve better post-operative results? Because maybe a femto system helps you achieve a better rexis or something?
Yes, I've worked with the Zimmer Z8 femto laser for cataract surgery, and one of its key advantages is ability to create a perfectly round, precise, and evenly sized capsular rexis. This consistency is critical for optimal IOL positioning, especially for patient lens premium lenses like Toric multifocal IOLs. Additionally, the laser enhances the safety and efficiency of the procedure by softening the lens for easier fragmentation and reducing the energy needed during phaco emulsification. But first reason advantage
Yes, first
is
advantage.
capsular access.
Capsular access.
Yes,
Perfectly round capsular access.
perfectly round and with exactly the size that you need.
Thank you so much. So the last question would be from a doctor from Cần. Hello, Dr. Evgenii. I'm another doctor from Cần. And what about opposite clear corneal incision on the steepest meridian? I usually perform my corneal incision at 11 o'clock. So, for example, the steep meridian is at 170 degrees. Would you change the position of your main corneal incision then? And how much degree of astigmatism can this type of incision reduce?
Clear corneal incision has several notable limitations. It must be performed along the steepest meridian, which isn't always convenient for practical during surgery. Additionally, clear corneal incisions is more effective at reducing astigmatism rather than completely eliminating it, making it less reliable for precise correction. The results can also be unstable over the time due to corneal healing and regression, particularly for higher levels of astigmatism. Unlike Toric IOLs, clear incisions doesn't allow for post-operative adjustments if the outcome isn't optimal, like LRI. And finally, clear corneal incision do not recommend it for use with multifocal IOLs, as any residual astigmatism can significantly affect the visual outcomes of these premium lenses. So this limitation highlighted why Toric IOLs are more predictable and effective solution for astigmatism correction.
Thank you so much. So that was the last question. I hope that we have answered most of the questions from our viewers and from me also personally. Thank you so much. So in case if there are any questions we haven't addressed, please write to our Facebook account, to Dr. Evgenii Chernov on Facebook or my Facebook, Dinh Hoang. And I hope that with this podcast, more surgeons would start to use Toric IOLs, so we can have more Toric IOLs in stock in Vietnam.
Of course.
So we would not wait 4 to 6 weeks now for Toric IOLs. So thank you so much again for joining.
Thank you for having me.
Let's wait for next episode of our podcast.
Okay, thank you. Bye-bye.